A lot of people have like a very big denial that they do not have depression.
One, if you are waking up at least 2 hours before your usual time and racing of negative thoughts start. Second is suicidal ideations. If you're having suicidal active thoughts, making plans, Googling about it, wanting to give away your possessions, please seek help.
What exactly is schizophrenia?
If imagine one parent has the diagnosis of schizophrenia versus if two parents have a diagnosis of schizophrenia, there are about 48% chances of the offspring having schizophrenia. Still, I've seen kids come with their parents. The parents are my patients. These kids haven't developed schizophrenia in their 20s or 30s or so on. A gene will express itself when the environment is causing it to as well. So, those hallucinations or delusions. For example, I can hear somebody talking about me sitting in Andhra Pradesh and I know that they're speaking ill about me and they're saying, oh look, I'm sitting with you, or they're going to come behind you as well. The patient kept looking behind me and I was very intrigued and kept looking behind me and after a point I said, what are you looking at? He said, there's a kid standing behind you. And I said, what? We have things beyond medication now. Earlier I mentioned something called non-invasive brain stimulation. Now that's beyond ECT also. ECT, maybe you've seen it in one of those barbaric movies where they're giving electric shock to a person.
Stimulation.
Trust me, and I'm going to say this, and I hope more people open their minds up to ECT. ECT is a godsend, it's a life changer. You can see patients get better like this.
So Dr. Era, what is this podcast all about?
Anant, I'm so excited to talk about schizophrenia, bipolar affective disorder, not to miss not narcissistic personality disorder, your favorite. We also spoke about psychedelics and ketamine and something controversial, which is electroconvulsive therapy, guys, something that you must have never heard about earlier. What did I forget about? Anything else that we talked about, or should we let the viewers watch till the end?
I think we should let the viewers watch till the end. Dr. Era, welcome to Infinite Health. Thank you so much for coming today.
Thank you so much for having me. And before we go ahead, it's Dr. Era. I think मैं हर podcast में ये करती हूँ. It's become my life. But okay, if you want to
Dr.
say
Era.
yes,
right.
Please. Thank you so much.
I'm so sorry, Dr. Era. Welcome to Infinite
It's
Health.
probably my only pet peeve. Thank you so much for having
I'll
me.
make sure I use your corrected name from now on.
Thank you so
much.
much.
But Dr. Era, you are one of the most popular psychiatrists in Calcutta and you have a huge presence on social media. But just to start off this podcast, I really want to understand what a psychiatrist is.
You mean who is a psychiatrist?
Yes, because what do they do? Most of the time people get confused between a psychiatrist and a psychologist. So what is the difference there?
Before I talk about differences, let me tell you about the similarities. I think both psychologists and psychiatrists are up for the same cause, that is mental health. Now imagine a family which has so many members. So I like to think the psychiatrists are like the one child who went to medical school and then went on to do MBBS 5.5 years, MD for 3 years, went on to pick up a super specialization. We have DM in specific topics like addiction, geriatric, child psychiatry. And yes, then we can prescribe medication, we can diagnose you, we can tell which therapy is apt for you, we can refer you to the right therapist. We are also therapists, not all of us. Some of us choose to practice psychotherapy. A lot of us only choose to, do pharmacotherapy, that is medication. But we also do something like non-invasive brain stimulation, which are the newer advances in psychiatry. So that is about this one child that I talked about in a family of mental health. The other child went on and did their BA, MA, PhD probably, MPhil sometimes, in psychology. Now, that's the major difference. We are medical doctors, much like your gynecologist, much like your orthopedic surgeon, much like your endocrinologist. But psychologists are really our left-right hand because no practice is complete without working as a team. So if you ask me, because the next possible question is whom to go to, I say go where both of them coexist and work together in harmony, because that is the best place to go. You wouldn't want to go to an orthopedic surgeon who can't refer you to a good physiotherapist, would you? You'd want a team. You'd say, oh doc, do you have a physiotherapist working with you? Right. And they'd say, yes, I do. And that's faith, right? Because the right person will step in at the right time. So that is the psychologist versus the psychiatrist. We're not versus, we're actually very much together around mental health.
But in this podcast today, I really want to start with something very basic, and we will delve deep into a lot of diseases and basic protocols for brain health. But just to begin with, I want to start with something very simple, and that's depression. What does depression look like medically?
So medically, it is not called depression.
Okay.
Medically, it's called major depressive disorder. There's a difference. I'm sad, I'm depressed, I have a cough, I have a viral, I have the flu. These are all different terminologies. We tend to sort of intertwine them and overuse them and present them as just one cake, right? So depression is a very loose term. Major depressive disorder is what a clinician will use, especially when we put the diagnosis on paper. I will never write depressed. I'll write diagnosis, major depressive disorder. Because there are so many different kinds of depressive disorders in itself. There's recurrent depressive disorder. There's seasonal affective disorder. There's bipolar depression. Did you know bipolar can be bipolar up and down, but also down and down, which is bipolar depression.
Oh, really?
Yes, there is resistant depression. There is something called atypical depression. There's something called melancholic depression. So I can go on and on and on and on about different kinds of depression. And that's why when people say the term loosely depression, so as a psychiatrist, my first question is, what kind of depression are we talking about?
Right.
So still putting it for the most masses, major depressive disorder is something which has a clear-cut guideline, a clear-cut criteria, and a clear-cut timeline. What does that mean? Let me give you the example of tuberculosis. For tuberculosis, somebody should have been sick for at least 3 weeks or more, losing weight, having chills in the night, low-grade fever at night, spikes at a particular time, coughing if they have pulmonary TB. Of course, there are different kinds of TB as well. And then you start suspecting, oh, wait, this person may have TB, right? But before that, it's just isolated coughing sometimes, which could be also like an allergic reaction. Isolated fever, which could be just a viral flu, right? Similarly, just feeling sad is not enough. For at least 2 weeks or more, most of the time, that is pervasively and persistently, 3 core symptoms, at least 1 or 2 of them need to be there. Sadness, feeling lethargic, and just feeling like there is nothing to look forward to. And then there are a bunch of other additional symptoms. Sleeping too much or too less, more than your usual. How many hours do you sleep at night?
I try to get 6, 7.
So for you, 6 and 7 is average. For me, 8 is average. For me, going below that 6 mark will be dangerous. For you, going below the 4 mark will be dangerous.
Correct.
That's why that overgeneralization of 8 hours sleep doesn't fit everybody, right? Similarly, appetite changes. Somebody who probably eats this much now is eating either this much or it's barely eating, lost their appetite. The connotation most people have is that they lose their appetite. Some people actually overeat. That's the atypical version of depression. Similarly, lack of concentration. Constant feeling, suicidal thoughts that, I'm not worth it. I should just let go. Nobody wants me. Nobody will miss me. Along with sexual side effects for many people. Some people will come only with sexual complaints. And I say these are the tip of the iceberg problems. Catch them. And you dig deep and you realize there's major depressive disorder at the bottom. And just feeling irritable, snappy, not like your usual self. You need to have a bunch of these symptoms together. And still, depression will be mild, moderate, severe, and then there is severe with psychotic symptoms. So depression, major depression, depressive disorder also comes in a package of mild, moderate, severe with psychotic.
Right.
It's not that simple. It's damn nuanced. So
you just described a lot of people.
Exactly. So, people tend to overgeneralize and I say, itna aasan hota, then everybody would be able to make the diagnosis. There's a reason why you go to medical school, spend donkey years and then say, oh, this person has major depressive disorder, severe, recurrent, without psychotic symptoms.
Right.
That's a diagnosis that I would try.
But I have to ask you this because a lot of the symptoms you said, even I resonate with, at some different points of my life.
Not at the same time. That's why I said 2 weeks or more, most of the time, at least. I do not say over your entire lifespan. Of course, that's like you've had cough separately, you've had fever separately, you've lost weight separately. It doesn't mean you have TB.
No, but there are some symptoms, when you mentioned the first 3 symptoms, I've had them for say weeks at end or 2 months or 3 months as a phase. What I'm trying to ask is, when should I be concerned enough to go to you?
Now, the word disorder was the part that I did not end up describing. Disorder, by definition, means something which is going to affect your biological drives, sleeping, eating, and your day-to-day activities are affected by it. If your day-to-day activities are getting affected by it, if your relationships are getting affected by it, people around you are getting concerned, if you know that this is not your optimum, and then yes, definitely your work will be one of the first key things for a student. It'll be their studies. For somebody working, it'll be, the way they function optimally. That is the definition of a disorder. And that's when you definitely should seek help.
But what if someone's living alone? Because, we are living in a corporate world right now where people are transferring to different cities and they're living alone. And what if they don't know that they're depressed? Because a lot of people have like a very big denial that they do not have depression. Like, what do you do in that case? Like, are there certain, of course, you mentioned the certain signs and symptoms, but are there certain tics or then certain things that they can check that, that I might have depression, that I now need to go see a doctor?
I'm going to answer this in two parts. One, not as a diagnostic litmus test, but something that you should consider and then definitely run for help. One, if you are waking up at least 2 hours before your usual time, so if you wake up at 6 a.m. and you find yourself awake at 3:34 and racing of negative thoughts start. So this is called early morning awakening. Again, this is a soft sign. What we mean by soft sign is not necessarily a litmus test that ye hai to wo hoga, but definitely this is a very good hallmark, one. Second is suicidal ideations. If you're having suicidal active thoughts, making plans, Googling about it, wanting to give away your possessions, please seek help. These are two absolute non-negotiable ones. The other part is the optimist in me going to propose something. I wish mental health becomes such a common household name that just the way if my teeth hurt, and even if they don't hurt, I go to a dentist at least once a year, if not twice, recommended. And the dentist tell me, hey, your teeth are good, or you have a cavity. Probably mental health could become as accessible and as feasible for everybody and non-tabooed and non-stigmatized that we just casually go and see a psychiatrist or a therapist regularly enough to know that, hey, everything is fine versus, hey, I'm concerned about you.
Right.
But that's the optimist in me.
No, but I love what you said, because I have been going to therapy for the last 7 years, and I even sometimes when I'm very happy, I'm in a good zone, I'm focused, I still will always make time to go at least once in 6 months or once a quarter just to talk it out.
Absolutely. So like dental health, I wish mental health was also as promoted with those teeth, nice sparkly teeth ads. I wish mental health was also
I always try to make these protocols for people for mental health. I'll definitely put this as a first point. Visit regularly, like at least once in 6 months.
Yes,
for
absolutely.
Sure.
I go to therapy and whenever my therapist says all is well, it's fine, and I'm like, no, but I'd just like to come in once a month, once in 2 months. Is that good? I'm like, of course, you're welcome. So that's a good enough way to know that, everything is fine, especially from a third neutral party, because often we are not only in denial from self, but also we despise our loved ones pointing it out to us that something is wrong. In such a case, a third neutral agency coming in and saying that, yes, this does not sound like something that you should be struggling with. This does not sound like a good quality of life for you. You've told me that, listen, you would go and run marathons earlier and you were possibly functional for 8 hours a day. And now you're saying you can only go work out once in 6 months. And now you're only getting 2 hours of work in a day. I'm concerned about you.
Right.
But that from a neutral person is more acceptable to a lot of us, isn't it?
Dr. I have 2 more questions on this. The first being, is this depression related to your genes?
Absolutely. In fact, for all mental health disorders, we have a biopsychosocial model. What does that mean? In the bio part of it, it's genetics. That means things that you've been passed down from your family. That is why certain conditions are more in monozygotic twins than dizygotic twins, than just siblings. Second part is your brain chemistry. That is the other part of the biology. The third part is your hormonal system, especially more particularly nuanced for women, of course. The drugs and any other metabolic diseases, that's the biological part of the biopsychosocial model. The psychological part is your personality. Why do 2 people see the same situation differently? If some tiger enters this room right now, you and I are probably going to react differently based on our personality, based on our learned experiences, based on what we've seen growing happening in our families, how responsive or reactive they are. So in the psychological part, it is your personality, your traits, your coping skills, any traumas or any kind of abuse that you've been through in the childhood. And finally is the social part, because we are social animals. So any mental health disorder can get precipitated when there are stressful social situations. COVID was a perfect example, I think. Breakups are a very common place where major depressive disorder surfaces. Death or grief is a very common place as well in the social context. So yes, in that, the biological part, genetics is one of the most important parts.
So, if someone is positive for those genes where it passes on from one family to another, how worried should a person be if they have a family history of mental illnesses? Say I'm someone who's okay in life or doing okay, but I have a whole family history of mental illnesses. Should I come to you and get that genetic test done?
You should be just about as worried as if you have a family history of diabetes, which means you should be careful, but not so concerned that you can't sleep at night, because that means you've become very anxious about it. So this is a very common thing that young people, especially millennial folks, will come to me and say, doc, my father has this diagnosis, let's say alcohol use disorder. My mother has major depressive disorder. And my grandmom used to have some diagnosis. I really don't know what it was. I'm very concerned. What are my chances of going on to develop ABC disease? So I tell them, before I give an answer to that, what will you do with that? What would you do with it?
Right. I don't know. I'm personally the kind of person I am. I would preferably go with the test.
Forget testing. What would you do with that piece of information?
I don't know. Again, I think I like knowing personally, and I think I would be cautious about the things that I do. Because we were discussing this earlier before the podcast, that I had a gene, the APOE4 gene, which makes me at a 10 times higher risk for Alzheimer's. And I think that a lot of me has changed because of knowing that piece of information. But that's me personally.
Because of the fear.
Because of the fear that, I have stopped smoking, I stopped drinking, I do brain health exercises, and, I take omega-3 supplements, walnuts for brain health and such, but all good things. But again, I get your point where everyone might not react to it in the same way.
What is the intention behind that question? Is my question always. Meaning, what would you do with that information? Because knowledge is power. And I don't like to gatekeep information from anybody, whether your chances are X or your chances are Y. But knowledge without action is horrible.
Right.
It's nothing. It's trash. It belongs in the trash bin. So if you've come so far in wanting to find out so much, and sure, we'll get to the answer of that, there is no particular genetic test that I can give you that will give you 100% guarantee of what are your chances for major depressive disorder. But how would you like to learn to possibly avoid the psychological and the social aspects? Because biological, what you've been handed down, you can't change your genes. But the psycho and the social part you can work on, right? The lifestyle you can work on, right? So schizophrenia is one such condition where we have very clear percentage stats. For example, monozygotic twins versus dizygotic twins. More monozygotic twins will have the same schizophrenia diagnosis versus dizygotic. Versus if imagine one parent has the diagnosis of schizophrenia versus if two parents have a diagnosis of schizophrenia, there are about 48% chances of the offspring having schizophrenia. That's almost 50-50, isn't it?
Right.
Still, I've seen kids come with their parents. The parents are my patients. These kids haven't developed schizophrenia and they're in their 20s or 30s or so on. So there is no hard and fast rule. A gene will express itself when the environment is causing it to as well. No gene will just express itself just like that. Going back to my initial diabetes question to you, just because there is a family history of diabetes doesn't mean that I'll automatically develop diabetes. Should I be more careful? Yes. I quit sugar 13 years ago, 12 years ago, completely white sugar, no desserts. Once in a while, of course, but just no processed white sugar because I have a family history of diabetes. And as a 20-something-year-old, I was like, I don't want to develop diabetes. Now I realize, yes, that kickstarted a lot of good habits, just like yours did. But it's not scary anymore. If it is supposed to happen, it may happen. I've done what is under my control. Right. Genes are not under my control. Lifestyle is. So that answers, yes, there is a genetic big component to it. Don't be afraid of it.
Now, before I move on to my actual question, I want you to explain what epigenetics means in terms of genetics being an essential component of disease.
I'll try to make it as simple as possible. So, earlier, one would believe that you could not do anything with your genes. You can't change them, no matter what. In the recent times, we've come to realize that with the right lifestyle, with the right changes, with the good positive biohacking, and just taking better care of yourself, you can bring about positive changes in your genes, which will then go on to pass off onto your offspring, of course, depending on your partner as well. Same goes for the negative, which means if you've been through extreme trauma, if you've been handed a very bad card when it comes to, let's say, poverty or mental health, and been through a lot of trials and tribulations, it's possible that your genes actually do get altered to have a lot more negative. That means a lot more chances of diseases, and you will also pass those off onto your children. That's epigenetics, as simple as I could.
So basically, genetics is not a death sentence. Like, even if you have some genes, like through epigenetics, like a good lifestyle, a plant food diet, exercise, having the right supplements, probably, you can change your genes, or there are certain genes that cannot change at all.
There's studies underway. There is no way to be very affirmative of saying all of it can be changed. But yes, a lot of it can be altered. There was once upon a time, we would believe that after a certain time, if your brain's neurons are dying, you cannot alter it. We've changed that. We've said that not only can you slow down, there's also neurogenesis happening even on later in life. Once upon a time, we said that till 18, your neurogenesis happens. So, we keep changing and updating on our theories. Now you can have neurogenesis at 60, at 65. Why not? So it's the same for epigenetics. It's work in progress.
Right. But, let's now move on to more serious diseases. Like, we spoke about depression, which is kind of common in general. Like, a lot of people speak about it.
We lose lives because of it.
No, absolutely. And I'm not trying to say that it's not a serious disease in general. But what I mean is, like, certain neurological diseases where people have no control over themselves, like something like a Parkinson's disease. Because this is something which is becoming like, in itself, it's growing at a 15-20% per year, and like so many people are developing Parkinson's as they age. Like, how does Parkinson's develop in a person who probably has had a great life in their life?
Again, genetics play a very big role. At the same time, yes, your lifestyle, meaning those who've had long history of alcohol abuse, those who've had bad lifestyle, then to have higher chances. Having said that, when you said that the rates are going up, I think the diagnostic rates are actually going up.
Okay.
So a lot used to happen back in the day. You must have seen older people whose hand would shake, or one hand would shake particularly, right? And we would say, what is this? And we would say, oh, it's normal senile aging. So Parkinson's gets diagnosed far earlier these days.
Right.
Again, I'm not the expert authority in Parkinson's. I'm going to say that outright. A neurologist is the perfect expert authority. My role in Parkinson's disease comes in particularly when there are psychiatric manifestations, which are so common. So most people, just to break it down, Parkinson's in the most common way for somebody to understand is a disease in which, again, not for very young people, but for elderly folks, one of their hands would shake. It's called a pill rolling tremor. And then if they're walking, they would be stooped and they'd be almost catching the gravity. And along with that, people forget that other than the motor symptoms, it's actually the emotional symptoms, which are also problematic. So there's something called labile affect. They'll be laughing and then they'll be crying the very next moment. They may do disinhibited behavior, behavior which is not really like them. Some of them do things which, they'd start sort of hurling abuses at you, which isn't really them as well. So there could be memory-related changes. There's Parkinson's dementia also. People hardly know about this kind of dementia. So there's tons of neuropsychiatric presentation. I'm the right authority to come to if, of course, because of the dopamine that is being given, you're having psychosis. Because did you know that excessive dopamine actually causes psychosis?
Right.
And what do we do to treat Parkinson's?
Dopamine.
Give dopamine.
Yes.
So there you go. And that is where a psychiatrist and a neurologist work together in tandem in saying, we do require this much dopamine. Please give them. But we also need something to then manage these psychotic symptoms. And that's where we work in tandem.
So how about some disease like Alzheimer's, which again is overlapping. So again, like Alzheimer's is something which is affecting so many people right now. I mean, is there something that we need to understand about Alzheimer's that we don't currently?
We have again changed the guidelines around this. Once upon a time, dementia was a very umbrella term used. We have something called mild cognitive impairment. You know that thing that we say with age happens to a lot of people? So there's a term for it. It's called mild cognitive impairment. It's not so severe enough to be put in the dementia category. Again, dementia is not only memory. people tend to only think of memory aspects. There's so much, there's emotions, there's motor movements, it's how you think, it's your personality, and so much more. Alzheimer's is a particular kind of dementia. So what particularly is on your mind when you want to talk about it?
No, like for Alzheimer's, I feel like again it's increasing at such a rapid rate, and like you said before, you might be right in the sense that it's being diagnosed more frequently now, and it wasn't diagnosed that much earlier. But are there good solutions and treatments available for Alzheimer's right now?
For Alzheimer's, I would say actually the rates have increased because of our lifestyle, which has gotten worse over the years. Once upon a time, if I had to come and see you today, I would have to walk and do nothing but walk. Now, what did I do? I got into my car and I came here, right? What I ate for breakfast is very different than what my ancestors would eat for breakfast. How we sit, we're sitting on these comfy chairs versus how they sit in a particular squatted position. So much change has happened in our whole entire lifestyle. So Alzheimer's rates have increased because of our lifestyle. Add to it the harmful chemicals in our environment because, there's aerosols, there's smoking, which is prevalent. There's just pollution. I think
Right.
we're like the pollution country of the world at the moment. So all of these do render a lot of negative. Eating in aluminum vessels once upon a time was very prevalent, which can also cause certain neurological and neuropsychiatric manifestations. But Alzheimer's, I would give you, yes, because of our lifestyle, it has gotten a lot more rampant. And yes, what I said earlier still stands true. Gets diagnosed a lot earlier. Earlier, it would not get diagnosed as much. What can we do to prevent? So much. Everything that I said is bad right now. We can undo those. Having said that, we can just delay Alzheimer's. We cannot prevent or cure it.
Right. If
so
you're supposed
far.
to have it, you will have it.
Yes. It's like diabetes, like I said earlier.
So, but does schizophrenia also fall in the same spectrum?
Do you mean that are the rates higher now because of the lifestyle?
No, like how does schizophrenia come into being? Because I'm very dumb when it comes to schizophrenia. I know that it is like where people start hallucinating and people have because there's so many people I follow who are also on Instagram where they are actually influencers who are schizophrenic. But I just wanted to understand, and for the audience and for my own understanding as well, like what exactly is schizophrenia?
Okay, first let me tell you how common or uncommon it is. It's just 1%. So 1 in 100 will have schizophrenia.
But that's also a big number.
It is big number, but then at the same time, it's not as big as how loosely people say, oh, you're a schizophrenic, oh, you're psychotic. So that term, just like how major depressive disorder, we usually use the term, right? So schizophrenia, first of all, how the cinemas paint it is very punitive and very harsh, I would say. It is not as scary always as it looks on TV. Having worked over the last 13 years with so many patients with schizophrenia, 1 in 100, which you can imagine that I probably see, 10, 15 people with schizophrenia that I diagnose every month, right? Now, there are two major subsets. One is positive symptoms and one is negative symptoms. What you described is something that we call positive symptoms. Those hallucinations or delusions. For example, I can hear somebody talking about me sitting in Andhra Pradesh and I know that they're speaking ill about me and they're saying, oh, look, I'm sitting with you, or they're going to come behind you as well. So that is hallucinations. At the same time, I still remember this was me learning and training and I could not sleep that night. This is my first year, I think, in MD, and a patient kept looking behind me. And I was very intrigued and kept looking behind me. And after a point, I said, what are you looking at? He said, there's a kid standing behind you. And I said, what?
That's scary.
But I had to really put up a brave front because I was training. And then I said, okay, we'll stop the interview right now. We'll come back. And I sent back and I asked my senior, is there really somebody behind me? He's like, no. This is the patient's, hallucination. Delusions are far more common. Delusions would be, I'm not going to have the water you offered me.
Okay, sorry, I'm just going to stop you for a second because this is a difference I would want to understand. Hallucination and delusion.
Absolutely. That's what I was going on.
I thought it was the same thing.
No. Absolutely. So how I teach it to my medical students is hallucination is through the 5 sense organs. What are your 5 sense organs? Eyes, nose, mouth, hearing, touch. That's hallucination. Anything to do with the disorder of that. It's called perceptual disturbances. And delusions is to do with your thinking.
Right.
How you think. So these are two different things, right? Thinking requires your brains and this requires your perception. So hallucinations could be, most common is auditory. Then I was describing a visual hallucination to you. You can have something like a taste hallucination, which is called gustatory. You can have a olfactory hallucination. You can have a tactile hallucination. You know, some patients are pretty convinced. One of my patients was pretty convinced that there's something put inside her which keeps fluttering. So there's a fluttering sensation which you would think is a, you know, extra terrestrial thing put inside her. At the same time, delusions are actually far more common, and you would know somebody who has delusions by default themselves as well. So they may not have schizophrenia, but they may just have delusions. And what would that look like? Somebody's following me. They know where I am. They put a camera here, which in today's time, by the way, is possible. But back when I trained, it was not possible, right? For example, I'm not going to have the tea that you offered me because I'm pretty sure you mix something in it because you don't mean well for me. So these are delusions and hallucinations. This is the positive side of the schizophrenia. It's called the positive symptoms of schizophrenia. And then there's a negative symptom of schizophrenia. These folks would be the socially aloof version of schizophrenia that you may have seen. You know, people who are quiet. They're not talking to themselves. They're sort of just cut off, blank face. They don't socialize. They're in their house. They don't eat. They don't trust. And that you would never suspect as schizophrenia. Family members bring these patients far later than compared to the positive.
So they are diagnosed much later.
Yes, unfortunately. I once had a lady who was brought 10 years after her first episode. Why? Because the mother thought she's just become introverted. So there you go. So schizophrenia is vastly misunderstood. And even in MBBS, I think I could not diagnose schizophrenia from potato to a potato. And it's only in MD that you learn how to pick up the nuances.
But then how do you treat them for schizophrenia?
You always need medication. If I say you do not need medication for schizophrenia, I'd be lying. You do require to regulate the dopamine. There's too much dopamine. There's not enough serotonin. You need to balance it out.
So basically, like, I'm just telling the difference. Like, so Parkinson's is basically when you don't have dopamine in your system.
Yes. And you need more from outside.
And you need more from outside. And in schizophrenia, you have excess of dopamine that you need to reduce.
Perfect. So that's why I say neurochemistry is like your brain is basically like a symphony. And any note which is excessive or too less is going to make like creaking sounds. It's not going to be symphony. It's going to be cacophony, right? So you try to titrate them and bring them in as much equilibrium as possible.
Right.
So that was nicely put, what you said about Parkinson's and schizophrenia. So there's so many versions. Again, once upon a time, we had different kinds of schizophrenia. Now we just use an umbrella term, schizophrenia. Along with that, also, you can have so much. So going back, what you asked earlier, are the rates increasing? That used to be there back then, there in the days. Well, diagnosis is increasing. Better treatment modalities are there. We have things beyond medication now. Earlier, I mentioned something called non-invasive brain stimulation. Now, that's beyond ECT also. ECT, maybe you've seen it in one of those barbaric movies where they're giving electric shock to a person.
Electric stimulation.
Trust me, and I'm going to say this, and I hope more people open their minds up to ECT. ECT is a godsend. It's a life changer. You can see patients get better like this.
Oh, really?
Yes.
So
psychotic symptoms.
It's literally electric shock therapy.
You know what is it? It's like giving your brain a controlled seizure.
Okay.
If you've heard of epilepsy, a seizure,
yes, of course.
Again, a domain that neurologists and psychiatrists share, by the way.
Right.
So there's Parkinson's, dementia, there's also, seizures. We share that as a territory because when the brain goes through seizures, it's very interesting. One of my patients presented with schizophrenia, had an actual seizure in the ward, did not require ECT, got better. It's
because
a natural
the seizure,
ECT.
Okay.
Yes.
So she's triggered the
yes.
ECT. Okay.
So it recalibrates your equilibrium in the brain. So ECT is a controlled seizure. It's perfectly safe, just like your surgery is. What do they do in surgery? They put you under in anesthesia. We do the same. What do they give you? Muscular relaxation. We give you the same. There's a small electric current passed. Perfectly safe for the patient, perfectly safe for the person giving it. I've probably given, without exaggerating, maybe 5,000 ECTs. And again, after a point, you say, you want your juniors to give ECT and you don't want to give any more. You're like, mera ho gaya, right? So patients, after 2 to 4 sittings of ECT, prior to ECT, psychotic. After 2 to 3 sittings of ECT, normal baseline. Prior to ECT, suicidal. Post ECT, suicidal ideation's gone. Prior to ECT, somebody had a manic episode. post 2-3 ECTs, fine. They do require medication though, along with it.
I'm just thinking out loud here, and I do not mean to demean any spiritual leaders or all those people, like, because, sometimes there are people and that I met in my life who call themselves spiritual or think that they see through the sixth eye or like, have more evolved consciousness. And like, in my mind, I always used to feel like, are they faking it for money? Or do they really believe that? I mean, I'm okay with people who are faking it for money because at least there's a motive and intention behind it that they're trying to make it into the world, and that's fine.
Okay.
But if they really believe that they have a sixth sense and that, they see on a higher plane or a higher level, could that be a sort of reading into the fact that they might be either delusional or hallucinating in some form?
For any of these to be diagnosed, we have specific things to ask. For example, what is the insight of the person into it?
Right.
How firmly do they believe it? To what degree do they believe it? Do they say, I can sit here and predict every stock market, every calamity, every Gaza, firing to who's going to be the next prime minister, president, everything? That is out there, right? Whereas to a certain realm, again, higher consciousness may exist, sixth sense exists in all of us, for that matter, right? And it gets activated in terms of danger, or it gets activated when we're even under duress and stress. So we do have these hallmark questions that we ask them if somebody's very convinced about higher power. Speaking of bipolar, I think most people think of bipolarity as only mood swings, whereas it's just so much more. I really want you to visualize a roller coaster. And then there's highs and lows. The lows, I think we already covered when we spoke about major depressive disorder, right? But what are the highs? Now, what I'm going to describe to you, if you tell me that even you've had, yes, we've all had it at some point, but you need to have them all together for at least 7 days at a stretch. So remember when I said earlier about major depression and you said, but even I've had some of these, and I said, sure, a lot of us have had it. But for 7 days or more at a stretch, if, number one, your mood is expansive, as if you won the lottery, even though you haven't, or irritable, along with it, you're having grandiose thoughts and ideas that I know the Prime Minister firsthand, he's on my speed dial. Or, you know what, I can make it rain in a different country. Or, I am so good at what I do. Maybe you are, but beyond the reality, beyond the expected limit. Along with it, not sleeping at night and saying, I don't need to sleep. Spending a lot of money. Recklessly shopping, recklessly indulging in sexual activities, maybe singing, maybe being disinhibited, dressing up in a manner that you're not, but a lot more louder. Again, that's not a personal statement choice. It's in these 7 days minimum that I'm talking about. And taking risky decisions in general, maybe even having a tryst with the law because you think you can drive wherever you want, you can park wherever you want. That encompasses, in a way, some of the features of mania. Now, mania is something that we, again, put in the psychotic spectrum. We need to treat it. We have delusions in them. We have hallucinations. Some of my patients have said that they are having a direct contact with the God at that time. God is coming and dancing for them. Or, they can summon God whenever they'd like. So circling back to what you were asking earlier, if this is happening in these 7-day period minimum and then going on, sure, I would then screen them for a psychiatric issue and the insight is lost, obviously. Whereas in the previous one that you were describing, leaders, self-proclaimed health gurus or spiritual leaders, I'd stay clear because I think there are a lot of echo chambers around them and yes, people who just agree with everything that they say.
Right.
So it's more of just that inflated ego or the narcissism that we talk about rather than a psychiatric bipolarity or a manic episode, so to
But
speak.
just something I'm thinking about, because you mentioned this 7-day period where a person has to go through it in a...
It's a diagnostic
7-day period. But like, I'm just thinking out loud like this, there might be so many people who are undiagnosed because who would actually think of getting them to the clinic? Because if I'm having the mania, I'm not in my right mind to go to a psychiatrist, right? Like I have to probably be... I don't know, a very aware person for me to go to a psychiatrist. Like someone would have to recognize that and see that and then get me to the psychiatrist saying that this is there.
On point. And that's why I do these podcasts. That's why I used to speak at so many community programs. I used to speak at corporates because when I speak about these symptoms, somebody listening to it goes like, oh my God.
I know a person.
My loved one has this. oh, I had to go to a psychiatrist and not only go to pray, and I really didn't only have to go to a general physician. That's how we spread awareness. One. Second part is actually more interesting for you. You would be surprised. So many patients with bipolar disorder. Yes, the first time they're brought. But over a period of time, there are some patients who develop enough awareness. I'm not joking. They flag me when they're about to have a manic episode, when they're still in something that we call a hypomanic episode, which means the baby of mania. Because I tell them, listen, do your mood charting regularly, flag me if you are having some or more of these symptoms together. They write to me, Doctor, I'm a little concerned. I've had a fight with 3 people this week. I've already bought more than my means. I haven't slept very well. Is this an impending manic episode coming? I'm sorry I skipped my medication for a few days. Or you know what, I've been just under so much duress. I have had my medication, but something is wrong. What should I do?
Right.
And I have at least 10 patients that I can vouch for who have done this in the last 4-5 years. And every time I read that, I say, this is an aware patient here. So they do end up coming back to you. If you can develop that therapeutic relationship with them, leave your door open and teach them how to identify.
Which means it's so important to have the right doctor working with you to
Therapeutic
go through
alliance. Anybody, anybody who, even a loved one can flag it for you, honestly. It doesn't have to be a doctor. But you need to have that alliance. You need to be listening
Because the
to
most
somebody.
famous example I know for bipolar disorder, and I know it's fictional, but it's Carrie Underwood from Homeland, if you've seen it.
Yes, but also Honey Singh came out and spoke about
Right.
his entire tryst with bipolarity recently. I think Selena Gomez has bipolar disorder and borderline personality disorder, if I'm not wrong. I'm not
Really?
very
I wasn't aware about
Yes, I'm
that.
not 100% sure. But a lot of these famous celebrities, when they talk about it, also then becomes relatable for people, right?
Right.
So,
But then how do you treat it?
okay. We again control the dopamine.
Oh, again, it's a
and we
dopamine.
reduce the serotonin this time. Too much serotonin because you're too happy.
Okay, too happy. Okay.
Don't need to be so happy that you
So
need
it's
to
high
be...
dopamine, high serotonin.
Yes, so happy that you're now basically giving money which you can't afford to give. You're buying things you can't. You can't buy 5 Lamborghinis in one go, right?
Right.
So people have made completely wrong decisions in these phases. So yes, we give antipsychotics. We give mood stabilizers. That's a different group of medication. For schizophrenia, it's just antipsychotics. And for here, we have something called mood stabilizers.
So the SSRIs? If
No.
I'm not wrong. Okay.
No, lithium.
Lithium, right.
Yes,
Lithium.
sodium valproate, something we use for epilepsy.
Right.
Carbamazepine, something that we use for epilepsy again. So many of my patients would say, why have you given me something for epilepsy? I don't have epilepsy. You lied to me. You said I have bipolar disorder. And I said, paracetamol too can be used for multiple uses, can it not? Right. So we have lithium as a gold standard. One of my patients joked that she said, I'm a battery. I have like lithium in my body. And, lithium is one of the gold standard tried and tested medication. But there's so many medication out there. And what I was talking about earlier around ECT, which, like I said, I wish more people had faith in it. There's also newer advances, which is the other non-invasive brain stimulation. So there's something called RTMS, that is repetitive transmagnetic stimulation. In this, you are not put under any anesthesia. You're made to sit in a chair. A big magnet is put on top of your head and waves, electromagnetic waves are sent.
Okay, and that doesn't hurt?
That doesn't hurt. It causes slight tingling in some people.
That's okay.
Headache in some people later. And again, 16 to 20 sittings over a period of time, X period of time, different parts of the brain, depending, do you have OCD, do you have nicotine addiction, do you have depression, what do you have? Different part of the brains will be targeted. And trust me, again, works beautifully.
A person I know, and I obviously will not take that name of the person, but it's becoming very popular in America, and they're using ketamine as a treatment for depression or
India too.
bipolar.
Yes.
We have it here as well.
Yes, absolutely.
Because ketamine was a drug when I was in college. Like it was something that people used recreationally.
Yes, but anesthetists have used it since time immemorial. It's actually an anesthetic agent.
Right.
So it's been used in the OT for forever. But yes, recreationally it got street value.
Yeah.
We are using it for major depressive disorder, which is going untreated. Psychedelics are having a lot of avenue. There's a lot of studies. Just not psychedelic assisted psychotherapy. So I did this Harvard there was this big meet where we learned from the best, and it was all about psychedelic assisted psychotherapy. But mind you, it's just not taking psychedelics yourself. It's the psychotherapy that has to be added to it.
Right. Under the supervision of doctors.
Absolutely. And it may become mainstream. It's already become mainstream in Australia, in parts of Canada, in US. They're looking at an FDA approval soon for at least psilocybin. And we'll see more. LSD probably.
Because I saw a documentary on psilocybin. It comes from mushroom, if I'm not wrong.
Yes. And LSD as well may get mainstream. Again, it'll be a pill. It won't be how party drugs
the blotting paper
Yes,
and
it won't
everything.
be the blotting paper. Exactly.
Right.
But yeah, going back, there's ketamine. Ketamine clinics are there in India. Ketamine clinics are by the bunch in America, of course, too many. There's intranasal ketamine, which has been released, much like something that you can just put in your nose, and it at certain doses helps with depression. There's oral ketamine that there are trials going under. There's just so much
Because the
happening in
most famous
psychiatry.
example of ketamine I know is Elon Musk. I know he takes it for his depressions.
And more recently, when we lost Matthew Perry because he OD'd on ketamine that from friends. So that was also in the news a lot. So misuse is always a problem.
No, of course, even the doctor, he accepted his guilt in terms of over prescribing the ketamine.
Absolutely.
All these mental illnesses that we spoke about, is it in any way related to narcissism also? Like, where does narcissism fit into this whole scheme of things?
Narcissism is an entirely different spectrum of mental disorders, which is called personality disorders. Now, as I was saying earlier, we all have a personality. Our personalities are different, but yet personalities can be broadly put under certain umbrellas, much like blood groups, right? Now, we have something called cluster A, cluster B, and cluster C. Cluster A is typically folks who may be very odd, eccentric, aloof. So we have terms like schizoid, schizotypal, and paranoid. Cluster B is where narcissism belongs. Again, I've still not said narcissistic personality disorder. Remember, I said disorders are different. Some traits of narcissism and healthy traits may exist in a lot of us. And used wisely, it's okay. Good confidence, they can go on kind of be leaders. But used to disadvantage of others, then it is a personality disorder. Then there's something called borderline personality disorder, if you've ever heard of it. Histrionic personality disorder. Similarly, in the third C category is something that we call obsessive compulsive personality disorder. You may have only heard of OCD, but this is OCPD. Then there is anxious and avoidant folks. Folks who don't get into relationships because they keep running away from commitment. So that style is borrowed heavily from here. So there are so many kinds of personality. Narcissistic personality disorder, again, always existed. I think thanks to media, everybody diagnoses their ex-boyfriend or ex-girlfriend as a narcissist, which is not the cool part because no, not everybody can have narcissistic personality disorder. Yes, there are some people who have it, and treating them is a hard job as well, to be honest.
Like even diagnosing them for that.
Diagnosing is easy.
No, I mean, like, I've always seen that narcissistic people, at least what I think, again, I might be completely wrong here and they might not be narcissistic really. But I feel like people who seem to be that they're narcissistic, like who have very high grandiose, feelings of themselves, they would never go for something like a therapy, or they would never go to a person because they might not have that kind of self-awareness for themselves. Like, I might be in a borderline wrong place.
No, not at all. Your overgeneralization is correct to a great degree, but you'd be surprised the number of people that are coming forward who have this diagnosis, who say, no, nothing's really wrong in me perhaps, but I still want to be better. So the idea is there's nothing bad in me, but I want to be even better than what I am. One. Second, more of them actually come when they bring a loved one to us and they say, my loved one is sick. What can I do to fix them? Because it's the I which is very, very strong, right? And the third is, I've had a pretty decent luck with a lot of patients that I've given this diagnosis to. And whenever I give a diagnosis of narcissistic personality disorder, I pray to God before I give one. Because I say, oh my God, today I'm going to get quite a big yelling. Because the most common response is, doctor, you're wrong. You're not qualified enough. You're too young. These are things that have actually been said to me. At the same time, there are people who say, I knew it. I'm glad that you said it. Can we not talk about it? And I say, okay.
Right.
And yet there are some people who then become so self-aware that they circle back and they say, you know what? I'm being very careful with my new partner because I don't want to repeat all the mistakes that I did because of my narcissistic traits and my personality disorder with the ex-partner. Can you help me in not making the same mistakes? So there is always that percentage. And that percentage, again, finding the right therapist, finding the right doctor, a good therapeutic alliance to be able to trust someone.
But there's no medicine there.
Medicines will be there because they usually go through a lot of depressive phases. Sometimes can have a lot of mood disorder, anxiety in general. So we can give
So
it
the
for
medicines
that
would be for
time-bound,
depression and
for
not
time-bound.
exactly
There's nothing
separately
for your
for...
personality.
Right.
And that's why a lot of them say, hey, what's the point of even working on me? This is my personality. It's like my genes. I can't change it. Is when I give them the epigenetics example we were talking about earlier. I say, listen, you can change anything that you'd like to. You're just 30, 40, 50. I have people in their 55s, wanting to change. And I say, it's not too late. If you want even 10 quality years, why not? Today's when you try.
I really want to spend a few minutes on the thing that you mentioned was on addictions. Like, there are some people who are very drawn to, alcohol, smoking. And like, there are some people who just cannot leave it. And there are some people who find it very easy to quit if they, even if they start something. Like, what is the baseline understanding that you have in this field of addictions? Like, how does it really work? Like, are some people more prone to addictions?
Absolutely. So first part is the genetics, back to genes again. The chances that if somebody, a loved one, first degree relative has addiction, your chances are going to be definitely significantly higher. But then comes the other part. For example, some people are very novelty craving. They always want new things. They get bored very easily. Such people are quite prone to addiction because their brain is always looking for the next high, the next hit. Some people have very poor harm avoidance. We use a term called harm avoidance. What does that mean? I'm not going to try to throw this because I'm scared, right? Whereas somebody is going to be so novelty seeking that they may want to open it, and they're so not afraid of harm that they may say, let me see if I fling it, what happens? So they're not afraid of even law. They're not afraid of the consequences. They'll always boast about how much they can drink, right? So they're not afraid of harm avoidance. And the last one is risk-taking appetite. Much like stock market, some people have more, some people have less. Folks with risk-taking appetite will automatically be gravitated more towards addiction. And finally is your conditioning, the society you live in, really. Because you see people smoking on the streets, and that is why it is just far more acceptable to jump onto that. If they make marijuana legal here, it's already, there are a lot of people addicted, but then there'll be a lot more people saying, oh, everybody's doing it. Why should I care about it? If you see your celebrity endorsing it, the pan masalas, you're like, it's okay. It's fine. How does it matter? If you see it happening in your house every day, all the more reason, why not do it? So that personality type does exist. We find them not only addicted to substances, but also behaviors.
Right. Like behavioral addictions.
Absolutely.
Because, in my head, like whenever I think about addictions, like the first thing that comes up to my head is cocaine or heroin. Because when I was in college, like a lot of people said, oh, you can take weed because weed is not addictive. But like most people said that because maybe I think that they had a line between medical addiction or like physiological addiction with, because they don't consider psychological addiction as a thing. At least young people,
Possible.
At least in my time, they did not think of psychological addictions as a thing. They used to feel like your body becomes... Because if I quit smoking, which I did, when I quit drinking, my body did not go through anything. It was all in the brain. Like I was craving for something.
Alcohol has physical dependence. Again.
In an extreme way, maybe.
Right. At the same time, I've worked in rehabs around the country, and what I observe is because cannabis is associated to be herbal by people and natural is why they don't think of it as addiction as well.
Right.
And in India, the connotation to gods comes in. That's why. But yes, cannabis is every bit can be habit forming.
No, I have a very strong opinion on this because I have followed Dr. Amen's research for the last 4-5 years, and like all the brain scans, and we've analyzed some ourselves. Like having weed is worse than smoking is my personal...
Both are bad.
No, both are bad.
Yes.
I'm not saying that smoking is good. Like in no way that am I saying that. But I know that weed literally like really shrinks your brain in ways that probably other addictants don't, and they consider it safe.
And then the number of people who, when the first wave when America legalized it in a few states, the number of people who sat across me and said, you are wrong, they have legalized it, which is why it is okay. I said, boss, even alcohol is legal in our country. So is smoking. Doesn't mean that it's good, right? A doctor isn't writing it. Now, when medical marijuana and this conversation comes, I think people get really, really confused. You don't have a medical diagnosis. You do not require medical marijuana. So don't overgeneralize, because people tend to, I have a very strong negative stand against weed as well. Very, very strong one. But what I find is that people believe in half-truths. And they just follow, Thailand mein legal kar diya, ab ye kar diya. So, cannabis is certainly the gateway drug, in my opinion.
Absolutely.
Folks who do it have higher chances of going on to other recreational drugs. Period. That's what I tell them.
I'm telling you, I was in LA like last summer and I was so scared of going down after 7 o'clock at
the
night.
The smell and the number of junkies on the road.
It's like, it's filled with it. Like, I was in New York, filled with people like that. In fact, I was speaking to some families and they were like, once they made this legal, it's like going out after 7:30 in downtown LA has become impossible.
You can imagine. This term junkies, it's very derogatory, but where does it come from? From the word junk.
Right.
Because that's what you become. And cannabis can precipitate psychosis, by the way. Circling back to what you were asking earlier, that what are the chances of somebody having psychosis? If you have a family history of mental health disorder, especially psychotic disorder, run away from cannabis, because the chances that it can precipitate it is many folds.
Absolutely.
Just like you said, you stopped drinking and you stopped smoking because you had the Alzheimer's gene positive. So you said, okay, let me cut out my risk factors. This is a very big risk factor.
I couldn't agree more. Like when I see people around me, I don't even say anything because it becomes like a very preachy kind of thing. And like, I feel like they will take it negatively and they will not believe because the truth becomes...
Show them this podcast.
Yes.
Absolutely.
No, but I absolutely agree. Like this is something that I feel very strongly about. But something that I have realized from this entire podcast, we've spoken about so many diseases, is that I think, and I don't know, you correct me if I'm wrong, but the entire brain mental health thing is like a game between dopamine and serotonin and oxytocin. Like
one more.
Yeah.
So the soda. So serotonin, oxytocin, dopamine, and adrenaline.
Right, adrenaline, soda. Of course. Fair enough.
Yeah.
So it's like the entire game of all mental, whether it's mania, whether it's personality disorder. By the way, I really wanted to talk to you about multiple personality disorder because I find it very interesting, but maybe sometime else. So it's like the entire neurological spectrum of all diseases, whether it's starting from depression to mania, to bipolar disorder, to Alzheimer's, to dementia, to Parkinson's and schizophrenia. Right? If this spectrum, if I have to put it in waves, is the soda waves.
Absolutely.
Right?
Something's going up, something's going down. Everything should be in harmony and equilibrium, but they're not.
And everything has to have a baseline effect, right? Like, because I am someone who studies aging, right? And I know that on an average person who probably doesn't have these diseases, like these things decline with time, the baseline. Like the baseline dopamine of an 18-year-old would be higher than a baseline dopamine of a 40-year-old, and so on and so forth. So dopamines keep declining with age, which is also a marker of aging in some ways.
Also, what you don't use also goes down by default.
Absolutely. So if I had to summarize this field in terms of making a general protocol for mental health, right? What would be the top 3 or 5 key points that you would say that one needs to follow, say a 30-year-old, 40-year-old who has started taking care of themselves, knows that mental health is a big issue? What would be the general protocol health advice that you would give for patients who want to take care of their mental health?
Anant, let me make it interesting by telling you what's in my bag. Have you seen one of those videos, what's in my bag, where people take out what all is in their bag? I think brain health and mind, I would like to put the both of them together at this moment, needs some very clear do nots and some very clear do's. And I always say start with the do nots. The do nots should be very, very clear. Don't do anything that will damage your brain health. Don't do excess of anything. I'm a big fan of please live your life. You've got one life. Don't do anything that you would not advise your loved one to do, that you wouldn't want your children to do. Now put whatever you'd like. You wouldn't want your children to smoke. Please go ahead, stick to that. And finally, don't let anything become your go-to for everything. Meaning don't stick to any kind of medication, supplement or any kind of protocol also that without that you start feeling jittery. Now let's talk about the do's. In the do's, I just want to highlight a few pillars. The first pillar is nutrition. The second pillar is your body. The third pillar is your social circle. The next pillar is something that you do for your own self. And finally is a medical pillar that I'd like to leave you with, of course. About nutrition, what you eat is extremely important. So make sure you get your vitamins, make sure you get your correct proteins, your good fats, your omega-3s. If you want to supplement, please supplement. Not everybody needs supplement. I think the ancient way of eating was great, where whole grain foods, not eating too much of ultra processed food, not going out too much was perfect. And that's what we need to do. If you need to supplement, check with your doctor, because no two people require the same form of supplement. But if you must supplement, find the precursors to serotonin, find the precursors to dopamine, find things that can manage the adrenaline. Those are good supplements to take for the brain health, along with something to enhance maybe your memory. Fish oil, cod liver oil, omega-3 fatty acid, DHAs are great for your brain health. What not to eat? For example, ultra-processed food, excessive caffeine. I see a lot of people do that. Eat very fast, another thing in nutrition. Next comes your body. I think 150 minutes may sound a lot, but 150 minutes of exercise in a week is doable for most average adults. So whether that's walking, whether that's, walking and talking, 7,000 steps, whatever you'd like, split that 150 the way you'd like, but should be doable. Please sleep well. Put those phones away at night. I think phones are becoming a major third limb for most of us. Revenge bedtime procrastination is on a high. Get that snooze at night. Waking up at 2 in the afternoon, sleeping at 5 in the morning does not count as good sleep. So that is the thing around sleep. So we're on to the third pillar now. The social pillar. Get oxytocin, socialize more, not only online, but face-to-face like the way we are, right? The next one is definitely something which can go a long way as a practice, whether that's meditation, gratitude, whether that's just journaling for that matter. Sometimes I journal 3 lines and I feel, oh, great, that's all that I want to journal, right? And the final is the more medical part. Like I said, I wish mental health became such a household common name that going to therapy or just seeing your friendly psychiatrist became a norm. And hence, adding that to the brain toolkit is also something that I propose. I know it's very utopian, but why not just put it out there that go speak at therapy and speak your mind out and see how you feel. So these are my 5 pillars for your brain and mental health. And definitely, please make them your own.
Dr. Era, thank you so much for these 5 points. I think this podcast has been one of those unique podcasts where my mind has really been opened, because I never thought about mental health in this way. Thank you so much for doing this with us. And I think this protocol will be set as a template. I'm going to write this protocol and share it with the audiences and share it with you as well for your approval. And thank you so much for doing this. Thank you so much for coming. This has been a wonderful podcast.
Thank you so much for having me. It was my pleasure.